All right. So tonight we're going to be going over gynecologic emergencies. This is the final chapter of the medical emergencies module. So again, most everybody is pretty close to being caught up. If you're a test or two behind, I usually don't concern myself. It's when I look at the grades and somebody's like 6 or 7 tests back, or they haven't even gotten into the module yet. We're already ending it, that kind of thing. Not to say that your deadline is not still by Thursday, right? So we know that this is the end of the third module, so this isn't the first rodeo for y'all. The um, the module is supposed to be complete by the time we start the next class, so that we all start the module at the same time. Um, Next up is trauma, and then we have special populations, and that's it. We're really getting kind of close to being done here. We're not in the home stretch yet, but we're pretty close. Trauma is easier than medical, because you can see what's wrong with your patient. That helps a lot. And really and truly, we really don't do a lot for trauma, so it becomes even easier just because most of it is stabilization and transport. The hard part of this class is what you're coming out of right now, which is the medical module. Um, just the amount of information overload, the amount of stuff that you're trying to figure out and you can't really see, it gets to be a pain. Give me just a second, guys. All right, guys, we're going to try to get back on this. Hopefully, I don't get interrupted again. That was one of my other instructors, so we will see. Anyway, let's move on. So tonight we're going over gynecologic emergencies. This is probably I won't say the worst chapter. This is going to be the hardest one though, because this one and childbirth are the worst because we don't do this very often, right? It's not even about your comfort zone and stuff like that, which that makes it difficult for a lot of people as well. But one of the main issues is that we just don't do this a lot, right? So this is the kind of thing that we really need to be when we're dealing with refreshers later on in our careers. This is the kind of thing that we need to typically focus on, not trauma or cardiac, because that's what we see every day. Give me just a little bit longer. He's calling back. All right, we should be good now. So I'm going to start off with this. This the first line on the slide. Don't misunderstand it. I'm not saying that this is y'all's purpose, but as far as a physiologic and an anatomical design, women are uniquely designed to conceive and give birth. You're susceptible to a number of problems that don't occur in men, or that you at least have more of a potential to get than men. Like for example, UTIs. We talked about that earlier. Women, based on your anatomy, you're just more susceptible to it. Guys can get it too, but it's not as common. The female reproductive system includes internal and external structures. For external, you have the vaginal opening, which is just posterior to the urethral opening. So if anybody has ever worked in a hospital, or if you are a girl and you've ever had a catheter, obviously you know this, but um, the urethral opening is anterior to the vaginal opening. Sometimes it's easy to see in the clinical setting, and sometimes it's not. And if you're ever in a position where you have to do a Foley, if you guys take your EMT certificate and you decide to go be ER techs and you ever have to do this, sometimes it's kind of difficult to find. The labia majora and the labia minora are folds of tissue that surround the urethral and vaginal opening. The clitoris is the anterior end of the labia. It meets right there. The anus is the post. No, I'm sorry. The anus is the posterior, and the perineum is the area of skin between the vagina and the anus. So that's pretty much the only anatomy lesson you need for external. Like I said, we're not going to get into the birds and the bees. That's not the intent of the class. For internal structures, the ovaries are the primary female reproductive organs. They are made from the same tissue that would have been testes had they been male. Ovaries lie on each side of the lower abdomen and produce an ovum. Um, an interesting thing about this is that every month the ovaries release an egg, and they alternate. So if a female has two functioning ovaries, January, March, May, so on and so on, they will say that they may come from the left ovary. February, April, June, um, those come from the other ovary. So they alternate. If a lady, for whatever reason, has to remove an ovary, that means that she is only going to be able to get pregnant every other month, because the missing ovary, the remaining one doesn't really pick up the slack per se. The missing one just means that she's going to go every other month without an egg. So it makes it harder for her to get pregnant if a cyst ruptures or something along those lines, and it causes one of the ovaries to either be damaged or have to be removed in any way. That's something that can happen. A fetus develops from a fertilized ovum. Fallopian tubes connect each ovary with the uterus, and those are not hard connections. Um, if we ever, I'm pretty sure the next slide is going to show it, but the fallopian tubes have what looks like a flower end on them, and they just kind of rake over the ovaries. They're not actually connected, which is usually fine. And the reason that they do that is they kind of, as an egg gets released, they kind of grab it and pull it into the fallopian tubes. But occasionally, sometimes they can lose the egg. Sometimes you get issues where things don't go where they're supposed to, particularly when a female gets pregnant. We'll start talking about ectopic pregnancies at some point, either in this chapter or when we get to childbirth later on. The uterus is a muscular organ where the fetus grows during pregnancy. The narrowest part of the uterus is called the cervix, and this is what opens into the vagina. The vagina is the outermost cavity of a woman's reproductive system, and it forms the lower part of the birth canal. So there you go. And here's a good picture. If you look on the left-hand side, the fallopian tubes, actually, they kind of look like a flower, and they grab the egg and pull it in when it's released from the ovary. Something else I want to point out, if you look at this cross-section on the right, notice how the uterus in a non-pregnant female, it kind of just sits and it lays over. It doesn't stay straight up. So as a baby grows, that the uterus will actually start to pull anteriorly as the baby grows. But normally, it just kind of sits and it lays. It's almost like it's laying over the top of the musculature below it. Let's see. That's all right. Yeah, no, I've got connection issues too. Sometimes if y'all have a problem staying connected, I understand. Just catch the recording. When a female reaches puberty, she begins to ovulate and experience menstruation. The onset is called the menarche, and it usually occurs anywhere between 11 and 16 years. So as you can see, that's a pretty wide range, right? Um, Anybody ever seen the movie Carrie, where the character in the show in the movie was well into high school when she started? Sometimes that happens, right? That wasn't in the movie. They made it out to be like this weird thing, but I mean, sometimes it just takes that long. Any female who reaches menarche is capable of becoming pregnant. So once it starts, that's when they're able to become pregnant. Women continue the cycle of ovulation and menstruation until they reach menopause, which usually happens around 50. Um, but again, it's not an exact number. So that can happen in early into the 50s, could be late 40s. It just depends. Each ovary produces an ovum on alternating months. So cool, they put that in the slide. This is our first class using this slide. I'm glad to see that they put that in there because that makes a difference sometimes when we're talking about some of the different issues that females can have. This process is called ovulation, and some women experience minor cramping pain during this release period. Sometimes minor is a major understatement. The process of fertilization begins in the vagina, and it's pretty much birds and the bees process from there. So we won't have to get into that. If fertilization does not occur within about 14 days of ovulation, the lining of the uterus begins to separate and menstruation occurs. That's why they have their cycle every month. All right, for pathophysiology, again, these are the things that can start to go wrong. The causes of gynecologic emergencies are varied, and they can range anywhere from STDs to trauma, and not just those things either, right? I mean, we can have, or I'm saying that we, but women can have gynecologic emergencies that are completely unrelated to either one. UTIs, yeast infections, any of those any of these things can happen, and they don't really fall into either of those two categories. Those are just the extremes. So some infections that we're going to come across: pelvic inflammatory disease. This is an infection of the upper organs of reproduction. So we're talking about the uterus and on up from there. Uterus, ovaries, fallopian tubes. This occurs almost exclusively in sexually active women. Um, Disease-causing organisms enter the vagina and migrate into the uterine cavity. It's not always the case as far as like sexually active or not, but we're talking about like 90-10, that kind of thing, maybe 80-20 on a conservative scale. This can result in an increased risk of ectopic pregnancy or sterility. We're going to talk about ectopic pregnancies later on in the chapter. Most common sign is generalized lower abdominal pain. So if you get a call for a female and say she's in her late teens, early 20s, anywhere in there, and she's hurting across both the lower quadrants, this is something that you may not be able to rule out. And unfortunately, there's really no way to know in the EMS setting, but we just want you to know what this is, kind of have an idea if it's not fitting all the other stuff that we're looking for when we talk about things like appendicitis, and you're like, well, I'm kind of at a loss. This could be what's happening. So some of your questions can be geared toward finding, maybe narrowing it down to see if this might be what it is. STDs, we really don't call them diseases so much anymore. They're STIs now as infections, but STDs can lead to more serious conditions such as PID. So there's a couple that we worry about. Chlamydia is the most common that you're going to find in the United States. This is caused by bacteria. It's usually mild or absent symptoms. Some women may report lower abdominal pain, lower back pain, nausea, fever, pain during sex, or bleeding between menstrual periods when they're not normally supposed to be having that issue. Some women, where is it at? Infection of the cervix can spread to the rectum and can progress to pelvic inflammatory disease. Bacterial vaginosis. This is the most common vaginal infection to afflict women ages 15 to 44. So stepping out of just in our country, and we talk about worldwide, we're looking at bacterial vaginosis. Normal. This is where bacteria gets into the vagina and it replaces the normal bacteria that's supposed to be there. So under normal conditions, any given day, a woman's vagina has bacteria in it, and most of it is there to keep a certain cleanliness, I guess is the best word for it. But sometimes that can get, if something happens, and it can be anything from medication to a sickness, if a woman is taking antibiotics, can cause it, that kind of thing, where the normal bacteria that's supposed to be there just gets swapped out. Symptoms when this happens can include itching, burning, pain, a fishy, foul-smelling discharge. If it's untreated, it can lead to premature birth if the woman is pregnant, or a low birth weight in the case of pregnancy in general, make the patient more susceptible to other serious infections, and cause PID. And notice everything kind of goes back to pelvic inflammatory disease. Gonorrhea. This is caused by bacteria that grow and multiply rapidly in warm, moist areas of the reproductive tract. Usually you're going to find this in the cervix, uterus, fallopian tubes. And men can get this. Actually, men can get all of these, but urethra in men can get this. And then bacteria can also grow in the mouth, throat, eyes, and anus. Symptoms are more severe in men than women. So you guys, y'all ladies, get the lucky end on that one at least. Women may present with painful urinating, burning, or itching, yellowish or bloody vaginal discharge, and blood associated with sexual intercourse. Some severe infections present with cramping and abdominal pain. You guys may get nausea and vomiting and bleeding between your periods. These symptoms indicated as progressed to PID. So if that's what you're seeing, that means it's gotten to the bad stuff already. Vaginal bleeding. This is bleeding that we sometimes mix up to be their menstrual period. So if you show up and they're bleeding, we ask them when the last time they had a period was, or we might assume that they're having a period. And a lot of times, especially in teenagers, because they're not regulated yet, women start to regulate to where they can almost plan out their cycles on a calendar as they get older. But when you're teenagers, it's not always the case. So a lot of times this can be overlooked or mistaken to be just a normal cycle. But possible causes include abdominal menstruation, vaginal trauma, ectopic pregnancy, spontaneous abortions, cervical polyps, or cancer. The good thing about it is that all of the bacterial infections, to my knowledge, and you guys correct me if I'm wrong on this, but all of your bacterial STIs, we have treatments for. There's antibiotics that kill pretty much everything. The three viruses are the main ones that we don't have a cure for. So, HIV, HPV, and HSV. We're moving into your patient assessment. Obtaining an accurate and detailed assessment is critical when dealing with gynecologic issues. And sometimes this is going to be very, very difficult because your patient's not going to want to be honest with you. You will be able to gain only a primary impression of the problem in the field, if for no other reason than dignity, right? But you should do a thorough patient assessment to help determine how sick the patient is and whether life-saving measures are needed. Just keep their dignity in mind. Get them in the back of the ambulance. Get them away from prying eyes. When you start asking them their history, especially when you get to those questions that are sensitive, like, are you sexually active? Is there any chance you might be pregnant? Don't ask that with mom and dad standing right over their shoulder. They're not going to be honest with you. Anyone who neglects to consider a gynecologic cause in a woman of childbearing age who complains of abdominal pain will miss a diagnosis at least 50% of the time. For your scene size up, it goes through your assessment just like anything else, right? So scene safety, BSI. Is the scene safe? Will you need assistance? And honestly, if you're a double male truck, or if it's, there's not a female present, you may want to consider having another truck come out with a female. Or if the mom is present, maybe have her there or something like that, just for your exam. How many patients do you have? What's the nature of the illness? And have you taken your standard precautions? It's going to be the typical things that you deal with. Gynecologic emergencies can involve large amounts of blood and body fluids, potentially contaminated with organisms that can cause communicable diseases. As with any bloodborne illness or any blood in general, we try not to get that honest. You don't know how sick your patient is. We don't know. They could be, unfortunately, a lot of times we're guilty of saying that, oh, we're working on the homeless lady. She's probably got all kinds of diseases, that kind of thing. The only problem with that is that line of thinking makes you disregard the possibility that the rich people um, might have it as well, right? So don't get pigeonholed into that. First of all, that's horribly offensive to your patient when you make those assumptions, and it's also dangerous to you because you should be protecting yourself regardless. So, where or in what position is the patient found? If she's at home, what is the condition of the residence? Is it clean, filthy, wrecked? Do you see evidence of a fight? Because that sometimes will play a major role, especially if you're worried about trauma. Are alcohol, tobacco products, or drug paraphernalia present? And does the patient live alone or with other people? If it's a crime scene, you may be required to testify in court regarding conditions on your arrival. So make sure that you do a good scene size up and take a good look around. Document as best you can. If you see anything that's out of place, put it in the report. Be like, I noticed this was on the table, this was in the room. We came through with there was a small, use all of your senses. If there's a strong smell that you feel like is necessary to put in your report, put it in your report. Paint a picture. So your documentation needs to be accurate and thorough. Involve the police if any type of assault is suspected. In cases of sexual assault, it's important to have a female EMT to provide patient care. Even unless it's a life-threatening emergency, even if you have to wait a bit, that's okay. For the mechanism of injury, the MOI in some patients with gynecologic problems may be easily understood from dispatch information such as sexual assault. If they tell you you're responding to a rape victim or a sexual assault victim, that's not something they usually mess up. So you can take that. You usually can take that to the bank. In other patients, though, patient history may reveal the nature of the condition. For your primary assessment, form a general impression. Is the patient stable or unstable? Use your AFPU scale at this point, right? We're still in the primary, so I'm not worried about a GCS. I just want to know one of four categories. Are they alert, verbal, painful, or unresponsive? We're going to check our ABCs. Always evaluate your airway and breathing immediately to ensure they're adequate. Give me an example. I'll tell you what, let's do this. What's the normal breathing rate of an adult?
Sitting still?
12 to 20. Good. That's your normal rate. So now that's not normally enough to determine whether or not somebody's breathing is adequate. What are some other things that we're going to put with this? If you're writing a report and you're describing somebody's breathing rate, or not just their rate, but their breathing quality, what are some keywords you may use?
Rise and
So
fall of the chest.
okay. So there you go. So one might be labored. They could be breathing 12 to 20 times a minute, but if it's labored, that's still not good. Shallow is another one that's also not good. Deep is one. There's a couple of different terms out there as far as like Cheyne-Stokes, Kussmaul respirations. You don't have to put those in these if you're just describing what you're seeing in the primary. You can just list it. It'd be like 12 to 20, non-labored, adequate breathing. If it's deep, you can put that. For circulation, palpate a pulse and evaluate your skin color, temperature, and moisture to help identify blood loss in the patient. If they have a ectopic pregnancy and it's ruptured, the amount of internal bleeding that can cause it will be a life threat, but it mostly will be internal. You may not see it. You're going to just see the other signs of it, like cool, clammy skin, right? You're basically looking at shock at this point because they're bleeding out. They're just bleeding internally. If there is significant blood loss, the patient may not be demonstrating obvious signs of shock, but may still be hypovolemic. The big thing you're going to notice is that their skin is going to lose its color. As soon as the blood starts to drop to the point where the body needs it in more places than just the capillaries feeding the skin, the body's gonna start shunting it away and putting it where it matters, which is the head and the chest. And when that happens, the skin starts to turn white because it's no longer got that nice blood supply to it. If patient has signs of shock, a weak or rapid pulse, or if they're pale, cool, diaphoretic skin, then rapid transport is warranted. And yeah, copious amounts of diesel, because as EMTs especially, we can't reverse shock. Even paramedics, the name of the game is to get ahead of it, not to try to pull somebody back from it. All right. So for your history taking, investigate your chief complaint. Some questions may be extremely personal to the patient. So, try to build that rapport, understand their surroundings, who's around them. They're probably not going to want to say a whole lot. Be sensitive to the patient's feelings and protect their privacy and dignity. That is huge. In fact, they will remember that more than they'll remember your actual patient care. Um, there's been calls where some people I've worked with have gotten thank you cards in the mail after something like this is going on. There's been calls where people have wound up in court after something like this is going on. And a lot of it just comes down to your bedside manner and how good you are at maintaining privacy and dignity. An adolescent girl may want to keep her sexual history private. That's normal. They're still at the age where they don't really want to admit to it when they're doing it, and that's even if parents aren't in the room. They really don't want to admit to it if they think they're going to get in trouble for it. For abdominal pain, ask about the onset, duration, quality, and radiation, provoking or relieving factors. So, again, think about the appendicitis thing. If you press on it, does it feel better? If you release, does it hurt more? Think about some associated symptoms like syncope, lightheadedness, nausea, vomiting, and fever. What is syncope? Very good. Passing out. Yep. Fainting. And yes, you're right, Corey. The patients and the family will always remember. And they will make their assumption about everybody else in the company based on the actions of whatever truck happened to be there that day. So it may not even be anything you did. You may show up to a house that had a previous call where somebody from your ambulance company didn't do too hot of a job, and you walk in the door. They don't know you from Adam, but they've got everything in their mind that they need to know about you because somebody else didn't do too hot of a job. That one truck is a whole department, pretty much. Anybody else wearing that uniform is the exact same thing. Vaginal bleeding, ask about, oh, I already said that. All right, so moving on to your sample history. To the right, there we go. Make a note of any allergies or medications she may be taking. If there is a chance of pregnancy, a lot of medications have pregnancy risk factors to it. So make sure you bring that to the hospital, at least a list, which if it's a young person, a lot of times the medication is not going to be that long. Ask about birth control. Ask patients about medical conditions and when they had their last period. And again, keep in mind, if you're dealing with somebody that's, say, like 16, their menstrual cycle is not regulated. So the whole they might be late thing is not, it's different than if a 30-year-old was late, right? Um, and then also there's a couple things, like I said, we just talked about birth control. Ask if they're on it. You should follow that up with, are you taking any antibiotics? Or any other medications? Are you current on your birth control? Because they may be prescribed it, but and teenagers are bad about this too. Oh, I'm 37 years old. I'm bad about forgetting to take my medications. Um, People may not, they may have forgot to take it that day. And some people will say there's no chance in that they're pregnant because they're expecting their birth control to work. But there's so many things that can mess it up. Antibiotics can render your birth control useless, even though you took it. It opens you, um, it hampers the effect of it, and you can still get pregnant if you're taking antibiotics. It messes up your birth control while you're on them. Also ask about the possibility of STDs. For your secondary assessment, you can perform this on the scene, especially if we're worried about dignity. If you're in somebody's house, then sure, unless it's like a life threat. If you see them, they're hemorrhaging, that's a problem. Get them to the hospital. If they're on the football field because it happens to be a cheerleader and she's having a problem at a football game, doing your assessment on the scene may not be the best option. At that point, obviously, get her in the back of the ambulance, get her away from people, do your assessment there. A lot of times, what we would do if we had that call, because I've had a couple like that, we just go ahead, treat it like she's unstable, and we get going. Because not only is it bad if the crowd sees you doing an assessment on somebody right there in the field, but if you put her in the back of the ambulance and the ambulance doesn't go anywhere for a while, the crowd's still watching and they're wondering what's going on. So just go ahead and start heading to the hospital. Pertinent secondary assessment findings should include vital signs, of course. So your blood pressure, pulse, skin color, and orthostatic vital signs. Anybody know what orthostatic vital signs are? We were actually discussing this in an AMLS class today. How some medications can mess with this. Yes, excellent. So it is standing, sitting, and lying down. You're going to get vital signs in those positions. Normally, if you go from lying down to standing up, because of the way our body works, your blood pressure should stay pretty even, right? You don't stand up and then pass out. When that happens, there's something wrong. So sometimes it does happen, and some medications will do that. It just depends. So when you go from lying down, where your body's not having to fight real hard to get against gravity to get blood flow, to standing up, initially all the blood's going to want to sink down to your feet. So your body is designed that as soon as it realizes that's about to happen, it clamps down on the blood vessels. Sometimes it will, pump the heart for a hot second or whatever, just to keep your blood flow going like it should, keep your blood pressure from crashing, that kind of thing. Depending on if you've lost blood, if you're on some certain medications, and then lost a considerable amount of blood, not just like a paper cut, your orthos may start to mess up. Where you go from lying to sitting to standing in less than a certain amount of time, and your vitals do crash on you. So that's something to keep an eye on there. That's a good sign that somebody has internal bleeding, because we can't see the blood coming out. So checking their orthos will let you know if there's any possibility that they've lost a lot of fluid. For your abdomen, you're going to look for distension and tenderness. Same thing. Distension usually means that there's blood in the abdomen. Tenderness a lot of times tells you that there's something that's wrong, like say an inflamed organ. For the genital urinary area, just look for visible bleeding. That's it. You're not a gynecologist. You don't have to go digging around or anything like that. And then for your neurologic system, just check their mental status. A lot of times, if they're hypoxic, if they're losing blood internally, if there's a UTI that could be spreading to their other systems, you're going to see a change in their mental status. For your physical exams, these should be limited and professional, especially if you are a male. Only examine the genitalia if it is necessary to do so to treat the patient. And even then, a lot of times, if it's not a life threat, just leave it alone. Take them to the doctor, let them take care of it at the hospital. You're not gonna fix whatever's going on. So if the patient is stable, just leave it at that. That is okay. Don't skirt your duties of taking care of your patient, but I mean, unless there's a life threat or something's really concerning you, just leave it alone. Protect the woman's privacy. Few women are comfortable with having their body exposed. So what we'll do a lot of times, if I do need to do a head to toe assessment, or if I need to assess something, especially if, and being that I'm a male, there's always at least probably one other person just there as a chaperone, just in case anything's ever said. We'll take a sheet, lay it across the woman's body, and we will just move the sheet to see what we need to see, cover her back up, move another part of the sheet, cover her back up, move another part of the sheet, that kind of thing, so that she's not just laying there naked. It's not very often you're going to find somebody who doesn't care. Limit the personnel present, but especially if you are the opposite gender, you need to have somebody there as a witness. Doesn't mean they got to look at the girl, but they just need to know that, if anything is said, hey, no, I was there, he didn't do anything. Be an advocate for her modesty. Focus your physical exam on the nature of the illness and the patient's chief complaint. For vaginal bleeding, visualize the bleeding and ask about quality and quantity. All right, if it's bad, because they can hemorrhage if it's really bad, but usually you're going to know because they're going to have blood-soaked clothes, that kind of thing. Use external pads to control vaginal bleeding. Keep the possibility of hypoperfusion or shock in mind, especially if you think that they might be bleeding internally. Always ask if there's pain associated with the bleeding. Never insert anything into the vagina to control bleeding, even a tampon. Do not do it. All right, because we're talking about possible major bleeds. That's just not something you want. And anything that goes in has to stay in. All right, I'll go and tell you all that now. So if you, for whatever reason, and we'll visit this again when we talk about childbirth, if you have to put your hand inside for whatever reason, it's not coming out. You're going to walk into the ER like that. Observe for vaginal discharge, make observations about the discharge, make sure you document. Fever, nausea, and vomiting are considered significant in gynecologic emergencies, and syncope is considered significant always. All right, treat as being in shock until proven otherwise. If they pass out, if there's a reason that even if you can attribute it to something like their orthos, that's a major red flag. So for your vital signs, you're going to assess the patient's heart rate, rhythm and quality, respiratory rate, rhythm and quality, their skin color, temperature, and condition. I know we've talked about it before, and we'll even hit it again when we get to trauma, but to check somebody's, the way that they feel, because we're wearing gloves, right? If you pull the glove up on the back of your hand and then just place that on their skin, on their, say, on their arm or something like that, that's how we're going to tell. Don't just like rip your glove off and grab them. We don't want to do that. Assess their cap refill time, assuming that the environment you're in is conducive to it. If it's 20 degrees, your cap refill is not going to be very good anyway. Blood pressure, consider obtaining orthostatic vitals if there is a lot of bleeding, or even if you suspect it. Pay special attention to the presence of tachycardia or hypotension, because those are big signs of shock. We've talked about compensated shock in the past. We'll hit on it again when we start talking about things in trauma, but you want to worry about that here too. This could, if they have these tachycardia and hypotension, it could mean hemorrhagic shock where they're bleeding out. For your monitoring devices, use a pulse ox if you've got it. There's nothing wrong with that. Consider using non-invasive blood pressure to continuously track patients' blood pressure. So if you've got access to a monitor, great. But non-invasive just means you're using a cuff. So even if you have to use a manual, that counts. It's the same thing. It's always recommended to assess the patient's blood pressure with a sphygmometer and a stethoscope. So if you have the standard, use it. A lot of times we get a little lazy and we start trying to use those monitors all the time, but it's good to get a manual just in case. Your reassessment is going to be the same as always. You're going to reassess anything you had to fix in your primary, right? So especially if there's something wrong with ABCs, you're going to make sure that whatever you did to fix that primary is still working. In the case of, like, say, an example would be make sure the tourniquet is still holding back the blood. In these cases, a lot of times what you're going to be dealing with in the primary is just giving your patient oxygen, stopping a hemorrhage if it's external. And unfortunately, there's no real easy way to do that. You just start piling pads up at the vagina, and that's the best you can do. Just check them, see if she's bleeding through. If she is, keep adding more pads, and then drive faster. If she is bleeding heavily, or you feel that she's otherwise an unstable patient where something may go wrong with her vital signs, reassess every 5 minutes at least. If she's not showing any signs that she's unstable, then every 15 minutes is fine. All right, for your emergency medical care, here's what we're actually going to do to try to help the patient. Maintain the patient's privacy as much as possible. I can't foot stomp that enough. If you're in a public place, move her to the ambulance. Have a female EMT, if at all possible, participate in the patient's care. If there's excessive internal vaginal bleeding, determine the cause of the bleeding. if you can, but don't waste a lot of time on it. This is not that important. So the big thing is we just want to treat for shock and transport. There's not a lot we can do. There's no way that we can really stop an internal bleed. The best thing we can do is try to catch it as it's coming out. Most women will use sanitary pads to control bleeding before you arrive. So if that's the case, um, see how many they might have used prior, right? If they're soaking them and swapping them out, ask her like, is this the first pad you've used? Is this all the blood you've lost, or is there a trash bag full of them behind you somewhere? Make sure you document that. That way, the hospital can get an idea how much blood she might have lost. If the woman has a tampon in place, don't move it. All right, just let it stay. The external genitals have a very rich nerve supply, so if something happens there, it's going to be painful. It's going to hurt a lot. They will let you know it. Treat external lacerations, abrasions, or tears with sterile compresses. Use local pressure to control bleeding. Use a diaper-style type bandage to hold dressings in place. And under no circumstances should you pack or place anything inside the vagina. Do not do it. Do not do it. Do not do it. I gotta do a better job of keeping up with the slides. All right. Managing the different things that we were talking about earlier. We'll start with pelvic inflammatory disease. A patient with PID will complain of abdominal pain. The pain usually starts during or after normal menstruation. So this can be during the period or right afterward. Inquiring about the date of the last menstrual period is important. Figure that out. And you should probably do that on any time you ever get a call like this. The pain may be made worse by walking. So in the interest of pain control, if you have this patient, yes, sometimes we do like to have our patients walk to the truck, but in this case, that's just being mean. So bring the stretcher to your patient. If you can't get the stretcher to her, use a stair chair, anything that you can do to kind of help her out. Pre-hospital treatment is limited. There's not really a whole lot we can do for these things. So get her to the hospital. But that being said, you don't have to go lights and sirens. PID itself is seldom a threat to life, but it is serious enough to require transport and evaluation in the hospital. For sexual assault and rape are common in the United States, to the point that 1 in 5 women have reported being raped. And we talk about this in the military. 1 in 5 report it. Can you imagine how many don't? All right, because this is it's a loss of control on their part. It usually winds up like the motive on most males' parts, and or even I'll just say the aggressor. It's not even just male, because men get assaulted as well. But it usually winds up being about control. So the victim had that control taken away from them. A lot of times it winds up being that it's actually almost just as hard for them to report it as it was for them to live it. So a lot of times they don't report it. 1 in 4 women will be sexually molested, often before the age of 12. EMTs called on to treat a victim of sexual assault face many complex issues. These do royally suck. All right. I can't, thankfully, I can't imagine it because I've never lived through it, but I can't imagine how much worse it is for the actual patient. Issues range from obvious medical ones to serious psychological and legal issues. You may be the first person the victim has contact with after the encounter. So how you handle yourself, how you handle the situation is going to be everything. And it's going to set the tone for everything else that goes on, no matter who is taking care of her. So your professionalism, tact, kindness, and sensitivity, as the slide says, are critical. When you're performing your assessment, be aware of drugs used during sexual assault or rape to incapacitate a person. There's a few of them out there, right? I mean, there's roofies. I've actually been roofied before on accident because the drink was actually meant for a friend of mine. There's chloroform, which doesn't really act like it does in the movies, but it still will knock you out if you're breathing it. So you may see signs of this, right? You may see an empty bottle laying around, or a lot of times roofies they get put in alcoholic beverages. So if a woman has been drinking, if you see alcoholic bottles around, that's something you may take note of. If there's an inability to remember the event, this should create suspicion. I remember the time that I got roofied. I think it happened. The last thing I remember was about 9:45 in the evening, and then I didn't really come back into my own head until almost noon the next day. Everything that happened that night, I had to be told what happened because I don't remember. I don't remember going out to the parking lot. Don't remember leaving. I don't remember my buddy Ryan having to carry me up the stairs to his apartment because that's where my friend dropped me off for the night to make sure that I was all right, that kind of thing. If these drugs are still in the patient's system, you may see hypotension, bradycardia, abdominal complaints, difficulty breathing, seizures, coma, death, if it's bad enough, altered mental status. If the drugs are still there, they may still not be completely in their right mind. So just be mindful of when you're asking the questions. If something is said that doesn't make sense, that should tip you off that there may still be some in her system. You can generally expect law enforcement to be involved. Attempts to immediately gather a detailed report from the victim may cause her to shut down. So don't push. Introduce yourself, be calm, stay out of arm's reach until she's ready for you to do an assessment. Don't just come in and get into her personal space, and understand that in these situations, the personal bubble is going to be a lot bigger than usual. Be calm, collected, use tact, make sure you convey a non-threatening stance and everything throughout this. If possible, give the patient the option of being treated by a female EMT. And again, just let her know, like, look, I'm sorry, our truck is two males. If you would prefer to be treated by a female, we can have one brought out. Just be patient with us. Because there's no telling at any given time where the nearest truck with a female EMT is going to be. Your focus should be on medical treatment of the patient. Is she physically injured? Are any life-threatening injuries present? Does the patient complain of any pain? Psychological care of the patient. Don't pass judgment. People are bad about that, right? Well, if you weren't wearing this, it wouldn't have happened. So on and so on. It's never the case, but people just get that in their head. Make sure that you don't, and if you do, just don't make it apparent. All right. Keep your thoughts to yourself, that kind of thing. Protect her from judgment of others on the scene. Preserve evidence. Don't cut through any clothing. All of that is going to be assessed. Especially if she had any rips in her clothing, that is signs of the struggle. If you go cutting through it, you've ruined it. Don't throw anything away from the scene. Place bloodstained clothing and anything else that can be evidence in separate paper bags. Don't let her shower, or at least dissuade her. Sometimes there will be like, I got to do it, and you can't forcefully stop her. But let her know that, look, that if you do this, it's going to destroy evidence. We may not be able to help you get this person to pay for what they did, kind of thing. It may be necessary to persuade the patient not to clean herself. I think that's is that on the slide? Because I know I just said it. Yes, not. All right. You should discourage your patient from urinating, changing clothes, removing her bowels, or rinsing out her mouth. Again, any changes like that, any cleanup is going to ruin a lot of the evidence. She's going to be photographed and examined by nurses trained in sexual assault examination and management. And again, this goes into what I was saying earlier. Sometimes going through this is almost just as bad, if not worse, than the act itself. Offer to call the local rape crisis center for the patient. Be there as a advocate for her. The police have to do their investigation, and they don't mean to treat people like objects and stuff, but some of it's unavoidable. So if you can be there, even if just to kind of help explain things to her, then a lot of times that goes a long way. Take the patient's history and limit any physical exam to a brief survey of life-threatening injuries. They're already going to be poked and prodded enough. We really don't need to make it any worse than it has to be. The patient report is a legal document and may be subpoenaed. And if this winds up being an investigation, you can pretty much guarantee that it will be. So write legibly, make sure you spell properly. They will be going through this with a fine-tooth comb, and they'll even judge you based on your writing style for this. So, take your time with it. Keep the report concise. Make sure you only do the factual information like we talked about before. If you're going to do something that, if you're going to write something in the report that is what the patient told you, you didn't see it yourself, make sure you write it as the patient stated it in her own words. And you can even put that patient states blah, 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 and put it in quotes. Don't insert your own opinion. Focus on the facts and bear in mind that rape is a legal diagnosis, not a medical diagnosis. So when you go to, when you're writing your report, make sure you keep that separate. And I believe that's going to be it. This chapter is actually really small. Yeah. Any questions on this unbelievably short chapter? Nothing at all. I know the last portion is always hard to get through, but all right, cool. All right, give me a second. I'll pull up your pen, and we will call it an early night. Did I say PID can be life-threatening? No, PID is not normally life-threatening, but it can cause. It's a progressive issue from other things, so it hurts a lot. When it gets unchecked, it can cause some damage to the reproductive organs and stuff like that. But no, it's typically not a life threat. So they need to go. Yeah, they need to go to the hospital. This is something you're not really going to want to just get a refusal and go about your day. But it's not something you want to turn the lights and sirens on for either. Just try to talk her into going, and then just give her a ride. All right, tonight's pin is going to be B as in Bravo, C as in Charlie, 2-3, G is in golf. BC23G. That's it right there. Yes, we are at the module 3. This is the last chapter of module 3. So before Thursday, actually, I'll tell you what, I'll give you guys, because I try to end the modules on a weekend so that you have a couple days to study. So we'll say that you have until the next Tuesday. So I'm going to give you guys to do your module test. So you can take your time, study this chapter, take the test, and then your module exam is due on Tuesday, even though we're going to go ahead and start doing trauma on this week's Thursday. So I'm not going to slow the class down. I'm just pushing the deadline back. Yeah, not a problem. That's, I need to go in and adjust that due date so you guys have more time. But I'll expect to see the module completed by a week from tonight. And other than that, y'all have a good one.